Bye.
Bye. So without further ado, and in the interest of time, I would like to introduce Dr. Madhuri Khilari. She is a neurologist and epileptologist currently working at Apollo Hospitals in Hyderabad. She did her MBBS from BJMC, Pune, and then she was interested in the field of neurology. And in order to pursue that, she started her residency in neurology at Jawaharlal Institute of Postgraduate Medical Education and Research Center, and there, she did her residency there. And then to further deepen her expertise in epilepsy, she pursued specialized training in NIMHANS in Bangalore and subsequently at the University of Bristol in UK. And after her training, she worked as a consultant neurologist and epileptologist in UK, and she has recently returned to India and have been practicing in Hyderabad for the past 8 months. And her primary areas of interest include the treatment of drug-resistant epilepsy and the pre-surgical evaluation of refractory epilepsy cases. Without further ado, I'll hand over to Dr. Khilari. Thank you.
Thank you so much for the kind introduction. So I would be basically, this would be a very interactive based session because I would be focusing on the salient clinical aspects. I won't be going into the details of how PET works. So I would be basically projecting how we utilize PET as a very important modality in investigation of the drug refractory epilepsy patients. So I would be basically discussing about the importance of PET scan in different kinds of epilepsy, and I will be dividing this into temporal and extratemporal epilepsies, and then I would be showing the kind of hypoperfusion we see in different cases of these temporal epilepsies and some of the extratemporal epilepsies. And I would be also discussing about how we utilize this in whenever we have a clinical dilemma, whenever we need to make a decision of whether to do an epilepsy surgery or not. And then I would be briefly touching upon the newer modalities, advances in PET imaging, and I would just be briefly telling the differences between INTERICTAL and ICTAL PET imaging, which I'm pretty sure everyone here would be aware of. So basically, we utilize PET in focal epilepsy by doing 2 kinds of scans. Very commonly, we use something called as an INTERICTAL PET scan. So INTERICTAL is in between the 2 seizures, and sometimes this differentiation can be very blurred. So we need to have very something called as a hypothesis to understand how much a PET is going to help in a particular case of drug refractory epilepsy. And we need to have certain clinical inputs. So we need to have an understanding of the clinical semiology, and understanding of how the MRI is, then understanding of how the ICTAL EEG is, and understanding the frequency of the seizures, because sometimes even though the seizures are not clinically apparent, it could just be a very frequent INTERICTAL electrographic seizures. And what we think clinically could be an INTERICTAL PET would in fact be an ICTAL PET. But other than these tricky situations, majority of the times what we use in our clinical for our clinical purposes is an INTERICTAL PET. So a PET scan lesions are more extensive than what an ordinary MRI would pick up, and that depends on the kind of epilepsy, that depends on the spread of the discharges, and it doesn't have any correlation with how intractable the seizures are. Basically, a PET scan utilizes the positron emitting isotopes, which are emitted by the radio tracers, and the photons are the paired gamma photons generated are detected, and this has a very a submillimeter millimetric resolution, especially in the cases of epilepsy, and which is way higher than an INTERICTAL or ICTAL SPECT scan. There are several hypotheses as to why people with epilepsy have hypometabolism during PET scan. It could happen because of neuronal diastasis. For example, because of the connectivity of neurons. Somebody who has a frontal hypometabolism can also, for example, somebody with right frontal hypometabolism can show cross-cerebellar diastasis and corresponding right cerebellar hypometabolism. So similarly, the neurons which are hypoactive in the frontal area can show hypometabolism in the temporal area. So because of the property of neuronal diastasis, it can happen because of loss of neurons, for example, gliotic focus, wherein it doesn't pick up it doesn't have any tracer uptake, and it's going to show hypometabolism. It can happen because of structural changes in the neuron. For example, neurons in epilepsy can develop arborization of the dendrites, and this can affect the uptake. And it can also happen because of functional changes. For example, it's a postictal neuron and it does not uptake the tracer. So these are the different mechanisms. There's another mechanism where there is activation of, there's inhibition of, this is very commonly seen in up to 20% of frontal lobe epilepsies. So there's one epileptogenic focus and it inhibits another non-epileptogenic foci in the brain, and that they can also present as hypometabolism. So these are the different kinds of PET scans that can be used in epilepsy. However, commonly, the most common modality used is the 18F FDG, and most of the scans that I'll be showing in this presentation would be the 18F FDG scans. Which in INTERICTAL PET scan present as a reduced metabolism. Whereas the ICTAL PET scan, it can present as a complex pattern as an increased or decreased metabolism, because sometimes it depends on the uptake of the FDG, and when there's a long brain uptake period, it can present as an as a decreased metabolism during the seizure, and after the seizure it can present as an increased metabolism. But these are I won't be going into the details of these. Again, similarly, the postictal metabolism can be complex. I won't be discussing about the details of the opioid serotonergic and dopaminergic uptake in epilepsy, because we don't commonly do that. But commonly in INTERICTAL PET scan, we see a reduced uptake. So I would be going now into the details of utility of PET scan in temporal and extratemporal epilepsy. So in temporal epilepsy, the hypometabolism can be seen inside and outside of the epileptogenic zone, because it depends on how intense the seizure is. Sometimes the seizure can just be in the form of an aura, wherein the patient might just get a feeling of, for example, a deja vu sensation or a rising sensation in an abdomen. And then the hypometabolism is going to differ compared to the patients with temporal lobe epilepsy who present with a little extensive seizure. For example, the seizure may spread to the basal ganglia, and they may develop a dystonic posturing, or it may, in rare cases, generalize. So it depends on the extent of the clinical presentation. So in which situations we get PET imaging done in epilepsy? We commonly look for a concordance in at least three modalities, and commonly three non-invasive modalities, in order to offer a patient an epilepsy surgery. So it could be the clinical history, the EEG and the MRI, or it could be the clinical history and the MRI and the PET. So we look for this triangulated evidence, and when all the investigations are concordant and when the lesion lies in a non-eloquent cortex, then we offer an epilepsy surgery. So coming to the classical TLE, I commonly do not offer this because of financial reasons in our country, but somebody who has a very classical presentation with aura, for example, a deja vu aura, an epigastric rising sensation, perioral automatisms, amnesia, and a very classical history of mesial temporal epilepsy, and if the EEG fits in, and if the MRI shows mesial temporal sclerosis, I commonly don't get a PET scan done. But this would help if either the EEG is non-localizing, so there are certain EEG patterns where the onset is diffuse, and it doesn't show very classical mesial temporal onsets. In such cases, we get it done, even if it's classical mesial temporal epilepsy, or sometimes we find that the MRI is completely normal and clinically we are suspecting classical mesial temporal epilepsy. So, we get the PET scan done. This helps in two ways. It helps in the triangulation of the evidence, and second, if we see hypometabolism in the temporal lobe, then we know that that region is hypofunctional and would also correlate with the neuropsychologic deficits in that zone, and then we feel more confident to resect that area. So commonly, mesial temporal epilepsy, if you got an interictal PET scan done, these are the PASCOM images from one of the articles I've showed here. It would show a hypometabolism in the mesial temporal region in the uncus of the temporal lobe and the anterior temporal lobe. And now I'll be discussing certain tricky examples wherein PET scan came to our rescue. So I commonly don't get it done for classical TLE, but I have other atypical examples of TLE wherein PET has helped us. So this was a lady with very frequent seizures, drug refractory seizures, and semiologically, they did not fit in the prototype of mesial temporal epilepsy. So she had an aura of dizziness, she had an aura of visual blurring. So there were some red flags for this to be a temporal, classical mesial temporal lobe epilepsy. Also, the onset was very early in her life. And she had bilateral mesial temporal sclerosis. And we had her admitted for a video EEG evaluation for 5 days. And all the seizures, we recorded 50 seizures, and all the seizures were recorded from the right mesial temporal region. So all the seizures were very typical of right mesial temporal epilepsy. But we did, this is the PASCOM image. So this we fuse the MRI and the PET, and this is an interictal PET, and we look for the asymmetry. So what looks very intensely blue here is actually an area of hypometabolism, which is very asymmetrical. So in contradistinction to what we saw in the video EEG, where all the seizures came from the right side, what we saw in the PET scan was significantly hypoactive left temporal lobe, and especially in the lateral cortex. So this was a red herring, and we did not offer this patient surgery despite recording most of the seizures from the right temporal lobe. This is the eggshell imaging and the coronal interictal PET, where you can see that there's still some asymmetry, but bilateral mesial temporal lobes are hypoactive. And the left-sided lateral temporal lobe is hypoactive as well. In contradiction to the articles which have present, which differentiate between different kinds of PET pictures and bitemporal versus unilateral temporal versus extratemporal epilepsies, they have mentioned that in the bitemporal epilepsies, you can have hypometabolism in the basal ganglia. But this is an amalgamation of 7 cases in this article, whereas what we saw here, her basal ganglia perfusion, basal ganglia uptake was all right. So how does a PET scan help in deciding the outcome after an epilepsy surgery? So if it's an ipsilateral PET hypometabolism, it indicates that around 86% of these patients would have Engel class 1, which is seizure-free outcome. And PET scan is the only modality which can help before the surgery to determine if this would be an Engel class 1 or 2, which is a significant degree of seizure reduction post-surgery, versus 3 or 4, which does not indicate a significant seizure freedom. A PET scan can also help in hippocampal sclerosis negative patients, wherein you strongly suspect a mesial temporal epilepsy. And this was an older study wherein they chose not to do the amygdala hippocampectomy in around 50% of these negative MRI patients, and they still had seizure freedom. So there was no difference in the outcomes. So sometimes PET scan can help you in titrating the degree of or the extent of resection, because in these patients wherein you know that the hypometabolism has not extended to the mesial temporal lobe, we can choose to spare this. Compared to the lesional temporal lobe epilepsies, wherein you expect a mesial temporal sclerosis, the non-lesional temporal lobe epilepsies would have more widespread temporal hypometabolism. And this can happen because of the involvement of the lateral temporal or the neocortical temporal structures. So PET in these cases helps by offering a prognosis. It helps by differentiating based on the patterns of uptake, whether it's a mesial temporal or a lateral temporal epilepsy. It helps in understanding if there's a hypoperfusion in the mesial temporal lobe, then you would expect some impairment in the neuropsychological functions. So it indicates that this is a dysfunctional neuronal network. So these are the different ways a PET scan can help you in offering surgery to the patients with epilepsy. Okay, so even patients with normal, non-localizing and non-lateralizing EEG could benefit with INTERICTAL PET. So this study had shown that in the patients with non-localizing EEG, around 73% of them PET helped. Also in patients with normal MRI, around 76% of the patient had positive findings on the PET. So that was about classical mesial temporal and bitemporal epilepsy. Coming to the lateral temporal epilepsy, I would just be starting with an example. So this was for a 3-year-old lady who clinically seemed to have something called as that looked like a mesial temporal epilepsy. So the aura, she had a very similar warning sign or aura like a mesial temporal epilepsy. And the clinical presentation based on the video EEG documentation was like a temporal lobe seizure. So arrest, perioral automatisms, brief seizures, and very rare tonic-clonic seizures. However, I won't be going into the details of the clinical presentation, but most of the onset in the seizure did not look like a mesial temporal, like a classical mesial temporal presentation in the EEG. It looked more like a lateral temporal presentation because of the very low frequency delta activity in the left lateral temporal lobe. And this was a PET scan, so it shows a massive degree of hypometabolism, especially if you look in these sagittal cuts, shows a massive degree of hypometabolism in the left lateral temporal lobe. And in this case, we know that we may need an invasive, if we choose to offer a surgery, we may need an invasive monitoring to exactly delineate the extent of resection. We know that this is not a classical mesial temporal epilepsy because it has extensively involved the lateral temporal lobe. This is the picture of the same patient. And this is from the article wherein most of the patients in this study who had lateral temporal lobe epilepsy did not have involvement of the uncus or the mesial structures. So these are classically spared in the lateral. So even if the clinical presentation is same, the semiology is similar based on the PET scan, and sometimes EEG could be non-lateralizing or non-localizing. The PET scan can help you by showing that the uncus is spared or the mesial hippocampal structures are spared, and this could be potentially a red herring for the classical mesial temporal epilepsy. Coming to temporal plus epilepsy, we epileptologists are scared of this condition because these masquerade as temporal lobe seizures. Only a very detailed history taking or red flags in the history or the clinical, the investigations can help us by telling that this is a temporal plus and it's not a classical mesial temporal epilepsy. So this is another example of a 29 years old female who had presented with a visual aura. So she used to see objects oscillating, and then she had classical temporal epilepsy that follows. So Jamia Swu, so strange sense of familiarity, and then arrest perioral automatisms, and was able to speak post-ictal. So only this red herring in the clinical history that she gets a visual aura that indicated that this could not be a classical temporal lobe epilepsy. We had her EEG done that showed very frequent right posterior head region discharges interictally by bilateral posterior head region discharges. And this is the ictal EEG, the beginning, where it shows the onset from the right posterior head region. The MRI brain was, unfortunately, it did not help. It was normal. And this is the PASCOM. So these are the fused images of the PET and MRI. And you see that there are different patterns of hypometabolism here. Classically, the mesial temporal structures are spared, but you see an extensive hypometabolism. You can see them posteriorly at the right posterior head region, the right occipital region, as well as in the right parietal region, what you can see in the coronal cuts, as well as anteriorly in the frontal region. So very extensive hypometabolism. This is again the picture of the subjects in this temporal plus epilepsy, where the study on temporal plus epilepsy, wherein they showed that there's extensive hypometabolism, which extended to the insula. It extended posteriorly into the parietal and occipital cortex. And this you would not see classically in either the mesial temporal or the lateral temporal epilepsies. So how a PET helps in finally choosing whether to deciding whether to do a surgery or not. So whenever you do a PET scan, in addition to the other investigations, you have a degree of concordance. So a PET would concord with around 66% of the invasive EEG onsets. Around 74% of these who have a non-localizing EEG, PET would be concordant. Or in 76% of these with a normal MRI, again, a PET would be concordant. Overall, it has a positive predictive value of 77.5% in the ones that have a non-concordant EEG or MRI. So in most of these patients in whom these investigations do not help, a PET, if the PET shows an abnormality, it has a very high positive predictive value. So it all actually honestly depends on the pretest probability. So if you think that the pretest probability would be high for this to be an extratemporal or a lateral temporal epilepsy, temporal plus epilepsy, and if the PET is positive as well, then the positive predictive value is quite high. So this is the table from the same article, which shows how PET scan helps in the cases in which there is a non-concordant MRI and a concordant EEG. So the PET can be extremely helpful in these situations. So this is another table which I made, deducing the data from that article. And you can see that 82% of the cases wherein MRI is normal, the PET can be in agreement with the other investigations. So for example, with the EEG or with the ICTAL EEG data and the clinical picture. And the odds ratio for the PET being the positive predictive value of the PET being high is especially it's especially significant for the cases where there's a concordant MRI and a non-concordant EEG. So the positive the p-value in these was less than 0.03. So again, so overall, the positive predictive value for all these investigations put together is around 77%. And for a non-concordant MRI or a PET finding, the positive predictive values were 83% and 86% respectively. So how much does a PET scan helps in extratemporal? So far we discussed about the utility of PET in temporal epilepsies, and we know that it's massive. So it can help in over 80% of these cases wherein one of the investigations could not be concordant. However, the utility of PET in extratemporal seizures is not well established. For example, in frontal lobe epilepsy, the utility can vary from 40% to 90% on an average. It helps in around 55% of the cases. And the utility of PET scan in occipital lobe epilepsies is also very low. However, it can be extremely crucial in certain situations. So it can help us detect some focal cortical dysplasias wherein it wasn't very apparent in the MRI brain, or in certain cases wherein you need to understand the extent of resection in these extratemporal epilepsies. It's extremely important. So here I'll be presenting a case of a young child. She is around 5 years old, and she has very frequent focal seizures, right facial contraction and right hand posturing. So we were suspecting some kind of extratemporal epilepsy in this, somewhere near the motor cortex. And she underwent a resection of the frontal cortex. And this was done somewhere else. And in the histopathology was consistent with the focal cortical dysplasia. However, the surgery failed. And she continues to have multiple seizures, again, in the form of right eyelid fluttering and right upper limb posturing, which can happen multiple times in a day. So this was her pre-operative PET scan fused with the pre-op MRI, and you can see that there's significant area of hypoperfusion here in the right precentral gyrus region, as well as in the right anterior frontal cortex, and it's extending to the basal ganglia as well. This, we fuse this with the MRI, and what you see here is not the pass count. So this is actually an ICTAL hypermetabolism. So this is an ICTAL scan wherein the patient had very frequent seizures, and what you see here is a significant uptake in the left premotor region, and you can see that the contralateral right premotor region is activated as well. You can see the massive degree of hyperperfusion here in the bilateral basal ganglia, left more than right. And this we fused with these images with the post-operative scan. And if you can see that compared to the lesion of interest, what you see in the PET scan, the lesion is just anterior to the precentral gyrus. And what the resections being done is way anterior, so which is why the surgery failed in this child. And now we know that based on the PET scan, you need to go a bit posteriorly. So it has to be at least involvement of the anterior bank of the precentral gyrus for her to become seizure free. So this is the superimposed bascom, and you can see that the resected area is way anterior to the region of interest. So the epileptogenic zone lies posterior. So PET is extremely valuable in such cases where you need to assess the post-operative failure when you're planning for a second surgery. And as I showed you, one of the scans here was an ICTAL PET. So it showed a hypermetabolism because of the very frequent ongoing seizures. And these were electrographic seizures. These were not seen clinically. This is why we significantly need to rely on our INTERICTAL EEG information whenever a PET scan is being processed. So coming to the pitfalls in PET. So PET scan can be challenging. For example, extratemporal seizures, we sometimes may not get significantly important information to bank on offering a surgery. Frequent electrographic seizures, such as what we had in this child, may give a misleading information because what was recorded was in fact an ICTAL PET. And if we go on looking for an area of hypometabolism, it's not going to be significantly useful. It may also help in differentiating between sometimes a poorly localized EEG or a poorly lateralized EEG. When the EEG doesn't lateralize, but the PET scan can lateralize. However, if a patient has failed a surgery and come to us, we cannot offer a new PET scan in these cases because of the epilepsy surgery. For example, if it's an anterior temporal lobectomy, because of the connections of the temporal lobe with the frontal lobe or with the occipital lobe, it would show hypometabolism in these cases. So in such cases, the pitfall doesn't help. Also, there is something called as an inhibitory phenomenon by an epileptogenic lesion. So you can see multiple foci of hypometabolism, which need to be differentiated from the epileptogenic lesion. And this needs to be, this can be seen in around 20% of the frontal lobe epilepsies. So an interictal slow EEG can significantly correlate with the PET hypometabolism. So coming to the newer advances in PET, so if you offer a combination of an interictal PET and an ICTAL SPECT, so overall for all the epilepsies put together, temporal and extratemporal, a PET has around 56% sensitivity in diagnosing the epileptogenic zone, whereas an ICTAL PET scan would have around 87% sensitivity. And if you offer a subtraction analysis of the ICTAL SPECT from the interictal PET, it can offer around 80% sensitivity in these cases. Also, whenever the PET scan does not correlate, around 80% of these, the SPECT scan can offer some positive, the ICTAL SPECT can offer significantly positive information. Just touching upon the newer advances in the PET imaging. So there are newer tracers coming up, and this is the the PET scan that utilizes the translocator protein and has shown a very high sensitivity compared to the FDG PET. This is statistically highly significant, and it can offer additional information to localize the epileptogenic zone. There are other reagents being harnessed, like the GABA receptors, the serotonin and opioid and dopamine receptors, which these are used in experimental settings. So overall, take-home message is you need to have a very high pretest probability in order to have a PET scan. PET scan would be extremely crucial when when you clinically suspect that this could be drug-resistant temporal epilepsies, but the MRI or the EEG are not concordant, and it can significantly help you in the epilepsy surgery failure cases when you when you superimpose the interictal PET scan and the post-operative MRI brain, you can harness this information in titrating the extent of resection in the second epilepsy surgery. So ultimately, this has to be a triangulated evidence, but PET scan is highly vital when you're looking for some additional information and the other supporting non-invasive modalities are negative. Thank you.
Thank you very, very much, Dr. Khilari. Excellent talk, very comprehensive, and a good correlation between, metabolic imaging and other imaging modalities. I'll start with, there's a question in the chat box by Dr. Halkar from MD University. So thanks for a great talk and giving us a perspective of an epileptologist. Can you describe your practice? How many new patients are seen per month? How many become drug refractory? And for after how long after therapy? Is EEG monitoring done before and after FDG injection?
Okay. So coming to the first part of your question, I see around 10 cases of epilepsy in a day, and around 2 or 3 of these are drug refractory. So maybe on an average around 15 to 20 drug refractory epilepsy cases. And we do offer them a complete, so PET scan is towards the end of our investigation. So we offer them an interictal EEG before we send our patients for the PET scan, for the before the interictal PET study. So we have an information, so we know that the patient is not having very frequent electrographic seizures before offering them an interictal PET scan.
Thank you. Dr. Josna's question is, she mentioned excellent talk. How about the role of PET MRI?
So some of the studies have shown here, in fact, we've utilized the PASCOM software. So this is a superimposition of the PET CT on our on the T1 weighted MRI images. And this is extremely helpful, especially in detecting the subtle cases of focal cortical dysplasias, because it just shows you the gyral hypometabolism, which otherwise can be very subtle, and you can miss it if you do not superimpose the MRI.
All right, thank you.
So it's very important in the extratemporal epilepsies, those PET MRI superimposition.
So you are primarily doing a PET CT, but co-registering the PET data on the most recent MR, correct?
Yes, yes.
In certain places like Emory, we do have PET MR. That's why, but I do not think that PET MR is available, very commonly across the globe. So, but I think co-registering also serves the purpose. So I guess I'll see more if there's more questions. So Dr. Chopra, who is our resident at Emory, how long do you wait before you inject radiotracer for PET if EEG is concerning for a seizure?
Ideally, we look for at least if the patient, for example, has had a massive seizure, then we do not immediately send the patient for a PET scan right after the video EEG monitoring. So we make sure that the patient is seizure-free at least for 6 to 8 hours before we utilize the PET.
So at Emory, usually we do EEG monitoring. When we inject FDG, then we do EEG monitoring until the patient is ready for this to undergo FDG PET. What if the patient has a seizure during that time period? Then you abandon the interictal PET, or do you wait for a certain time period? Since the FDG has been injected and the test was for the interictal PET.
So your question is if you had the dye injected and if the patient had an interictal electrographic seizure, how long do you wait? So the wait period should be at least 2 hours in such situations. Because of the unpredictable and prolonged uptake of the radioactive tracer, because what you're looking at is an INTERICTAL data. So ideally it should be around 2 hours wait period.
All right, thank you. And I see Dr. Moncayo was among the audience. She actually leads the neurology imaging in nuclear medicine division. Dr. Moncayo, do you have a question? Otherwise, I have one question regarding, as you mentioned, about mesial temporal lobe epilepsy versus the lateral temporal lobe epilepsy. Is there any prognostic significance between the two? One is the other to manage,
yes.
or?
So clinically, yes. Clinically, the mesial temporal epilepsies, you don't expect them to have very frequent generalized seizures, whereas generalized seizures are very often with the lateral temporal epilepsies. So with the very frequent generalized seizures, also the risk of SUDEP, the sudden unexpected death in patients with epilepsy can at least 1 in 4,500 patients. So prognostically, yes, it's different. Also, when you offer them an epilepsy surgery, and if it's an MR negative cases, we need to understand the exact extent of resection. So unlike in mesial temporal epilepsy, if it's a non-dominant cortex, we do sometimes offer them an anterotemporal lobectomy with the amygdala hypocampectomy. Whereas if it's a lateral temporal lobe epilepsy, we need to find the exact margins of resection. So we may rely on invasive EEG in such circumstances. So we do rely on the extradural grid monitoring or the stereo EEGs in such situations before we offer a surgery.
All right, thank you. Let's see. Dr. Halkar has another question. I see that you see a lot of cases per month. How often do you see heterotopia, migrational disorder as the cause of epilepsy, and how the management differs?
So I haven't seen many cases of heterotopia. I can count them on my fingertips. So it's not very often I have come across these cases of heterotopia. Honestly, so it has to that sometimes this could just be subclinical incidental finding in some of the cases. Especially if it's, for example, if it's along the ventricles. So this could just be a benign heterotopia, and there could be an additional lesion. So we need to look at the overall clinical picture before we think that if it's indeed the epileptogenic lesion or not. Migrational disorders, yeah, we do come across cases such as, sometimes it could be an extensive areas of hypometabolism in PET. So, for example, these what we call as MOGE presentation in the MRI. So we do come across such cases, and sometimes these cases need an extensive resection, or sometimes they do need an invasive monitoring to determine the exact titration of the resection. For example, it could be a massive area of hypometabolism, and clinically it looks like something like MOGE in the MRI. Then we offer them stereo EEG in order to understand which areas indeed need a resection, whether the entire area is epileptogenic, or if it's a focal area which needs resection. So it may not be the entire area which looks abnormal, could be epileptogenic in these situations.
Thank you. That's very helpful. Any more questions from the audience?
There's one question by Jigisha Chopra, which mentions how clinical presentation between lateral versus medial temporal lobe epilepsy differs. So lateral temporal epilepsy is commonly present with frequent generalized seizures. Lateral temporal epilepsies can present with vague auras, which could be cephalic auras, or they can present with auras of dizziness, or sometimes they can have auditory auras, which would not be seen in mesial temporal epilepsy. Mesial temporal epilepsy would mainly present with autonomic auras, epigastric rising sensation, or phenomenon of deja vu. Lateral temporal epilepsies very frequently can have other extratemporal features, whereas the mesial temporal epilepsy tends to remain within the temporal lobe and have these brief seizures which manifest in the form of arrest, automatisms, amnesia for the event. So that's how they differ.
Thank you, Dr. Khilari. And if we have no further questions.
No, I have a couple of comments. This is Raghu Halkar. At Emory, we occasionally, if there are discordant findings between PET and MRI and the semiology, then we do use occasionally interictal SPECT studies or ICTAL SPECT studies, interictal and
Yes.
ictal SPECT studies.
Yes.
We admit the patient and we inject, HMPAO and we do that study too.
Yes.
I don't know whether it is done in India very often. It would need hospitalization of patient and continuous monitoring of EEG, and
Yes.
logistically it can be challenging.
Yes, yes, absolutely. So it's not commonly done in many places in India. There are a few institutes that do it. The place where I worked in England, we very commonly offer an ictal SPECT for these patients. And yes, it does get challenging in patients who have very frequent seizures, because we need to have an interval of at least 2 hours, 2 hours of 2 hours before the seizure. For example, if the patient's had a seizure at 9 o'clock, the patient and another seizure at 8:30, then you cannot inject the tracer at that time. So you need to have a 2 hour seizure freedom before the seizure in question. And also in these brief seizures, for example, the seizures which in this focal aware or focal unaware seizures that may just last for a few seconds, for example, 10 to 20 seconds, very often these scans come as negative. So there are significant logistical constraints. Yeah, so it can be challenging, and yeah, we like ideally offer them the subtraction analysis, ICTAL versus ICTAL minus the interictal SPECT study. And yeah, it gets challenging when because of the tracer is not injected within the first. We aim at 30 seconds, but it's not injected within the first 10 seconds. Then it isn't massively helpful in majority of these cases, but can help in, I would say, around 1 in 4 cases of these tricky cases with non-concordant MRI and EEG.
About 15 years ago, the Jerome Angle from
Yes.
California had gotten a huge grant for randomizing patients at very young age, instead of putting them on medical therapy, identify the seizure focus and go for surgery. Because these drugs, by the time you give them for 10, 15 years, the patient's development has already been slowed down. So
Yes.
afterwards, if you do surgery, once they become drug refractory,
Yes.
even if the surgery is successful, the patient may not be very productive because
Absolutely.
of the long use of these anti-epileptic
Absolutely.
medicines. So he had a hypothesis, it's better to do surgery at very early stage itself.
Absolutely.
And
Yes.
we had we were one of the study centers, and we were the core facility to interpret the PET as well as MRI at Emory. And unfortunately, it was a 50 million grant from NIH, and unfortunately, in US, the recruitment for surgical arm was very, very minimal. And after 5 years, the NIH pulled the funds because most of the parents would not agree for a 7-year-old or an 8-year-old to go for surgery. So most of them opted for medical therapy. So that study could not be done. I don't know whether in India or in Europe that's a possibility where patients agree for what the doctor asks for or ready for
Yes.
randomization.
Randomization, unfortunately, I don't know how ethical it is today, because especially these cases of epileptic encephalopathy, wherein you know that it's a secondary epileptic encephalopathy. For example, somebody can have a structural lesion and then a Lennox-Gastaut syndrome. You know that when you resect the lesion in question, the patient is going to become seizure-free and is going to have a very good cognitive outcome. And the earlier you do, the better it is. Or even cases such as Rasmussen's encephalitis, you need to do a hemispherectomy very early in the course of illness. And the younger the children are, the better it is. So I don't know how ethical it would be to conduct such a trial to randomize them.
Yeah, NIH agreed and funded it in terms. So it was not an ethical question as much as acceptance by the parents to send their young subject their young child for a major surgery. That was the problem in US. And US recruitment of any cases for research is becoming increasingly difficult. People question it, and people do not want to be part of a trial very often. So that's a problem. I just want to give one thing. Saima, can you give me the thing? Do you know what is epilepsy called in Sanskrit? In Sanskrit, it's called apasmara. And there is a nice statue of Nataraj dancing on apasmara. And I just want to show it to you. That can be a great emblem for an epileptologist card. Simon, if you can give
privileges to you.
Privileges to me, then I can share my screen. Maybe.
Let me make co-host. So I've made you co-host. So go ahead. I think. Meanwhile, Dr. Maitri Shankar has raised her hand, so maybe we can take her question while Dr. Harka shares the screen.
Yeah, hi. Thanks for the great talk. The network was a little off. I'm not sure I was able to catch the second half of the thing. Maybe what I'm asking was already covered. So we have this Cortex ID and different softwares, right, which can kind of do the quantification. My question was, how accurate is it, and is anybody using it, or how reliable are they? That was my question, basically. It's the Cortex ID. It's a software, quantification software.
We do use a post-processing software to measure the thickness of the cortex. I don't know, honestly, our neurosurgeons use it, so I'm forgetting the name. But if it is so, we rely on the concordance of all these findings, and if it's for example, if it's concordant, the EEG and MRI, and if we the EEG and the clinical picture, the video EEG onset of the seizure, and if we do find one of the cases I showed in this was a temporal plus epilepsy, and clinically she had some occipital aura, and the EEG onset was from the posterior head region. The MRI was negative, but on the software we found some posterior cortex thickening in the right parieto-occipital region. So we are planning to do an invasive EEG. So again, it's an anecdotal evidence, and it can be useful if the other investigations support, if everything fits in.
Okay. And any experience with the PET MR? I'm not sure if it was already covered because I missed the second half. Because in Bangalore, NIMHANS has this PET MRI now, and they're doing a lot of these studies.
Yes,
I was just wondering.
I mean, we used to do it when I was in NIMANS during my epilepsy fellowship, but we don't commonly do it at the other places. So honestly, I don't like last few years I haven't been practicing that. But being in NIMANS, yeah, we used to commonly do that, and again, it's very like some anecdotal cases where it has been extremely helpful in diagnosing some of the focal cortical dysplasias, but no, I don't have much experience on it, honestly.
Okay. What we are doing is, we do the ICTAL SPECT and the INTERICTAL SPECT. And ICTAL SPECT is always such a challenge. It's so time sensitive. True. And, True. Any tips on, maneuvering through that, where radioisotope availability and nurse shifting and all these things are?
So it has to be, and yeah, we used to have significant challenges whenever we used to try doing this, the places wherever I've worked in the past, we need to have one dedicated technician reading the EEG continuously to mark the first onset of EEG, ICTAL EEG. So that's the problem. So that can sometimes, precede the clinical presentation, precede the aura, and then you need to make sure that it is indeed the habitual seizure that you're looking into, and injecting ideally within the first 30 seconds. But yeah, it's highly challenging, and you need to have dedicated technicians who only do that on the day when the SPECT scan is arranged. That's the only way to possibly avoid the significant challenges. Otherwise, it's it's technically quite challenging. Yeah.
One final question. This is Jyotsna.
And how much time is okay?
Oh.
Sorry, come again?
Go ahead, Jyotsna.
Yeah, so it's late, no matter how hard we try. So how much time is okay? Is it like 15 minutes is okay post-ICTAL or anything like that in that context?
So if you're looking for an INTERICTAL one, we need to have wait for 2 hours ideally for an INTERICTAL PET or for that matter SPECT as well, at least 2 hours.
Okay.
One question.
Jyotsna, go ahead. So we'll take Dr. Rao's question. Jyotsna. Jyotsna, you are muted. One of the questions that Dr. Jyotsna Rao put in the chat box, I'll read it, that one. After surgery, how do you follow up patients? And then Jyotsna can piggyback on that question. I think
So immediately after surgery, we do the clinical examination to rule out any obvious motor deficit, to rule out any obvious hemianopias the patient might have developed during the surgery. We plan for an EEG at around 6 weeks after the surgery, and we plan for a neuropsychological examination at 6 months post-operatively to see what the deficits are. And we plan for tapering the drugs, the anti-seizure medications if the surgery is successful at 1 year post-operatively. So that's how we follow our patients.
How often you see post-surgical gliosis causing epilepsy again?
That's an interesting question. So honestly, these mesial temporal epilepsy, so-called the seizure freedom of 70%, 70 to 80%, it depends on multiple factors, whether it was indeed a mesial temporal epilepsy, whether it is the if it's a complete resection, if it's the gliosis post-op which is causing the seizures, or it is a temporal plus seizure. So honestly, it's very difficult to split the threads and come to the conclusion that, oh, it is this which is causing the seizure, and if it's gliosis and it's not an incomplete resection. So it's a tricky diagnosis. But yeah, I have seen some cases of very rare stereo EEG electrodes, which can cause this cortical scars, which can be epileptogenic and cause seizures. So I've seen one such patient wherein we did a stereo EEG, removed the electrodes, and her seizures got worse. She got new semiology of seizures, and we did not operate on her, but seizures got quite worse after the stereo EEG, and the imaging showed cortical scars. So that's, it's not described in literature.
Yeah, I will share that screen now, just to give you a comical side to it.
Yeah.
Can you see my screen?
Yes,
We
I
can.
can.
And this is the Nataraj, the statue
Right.
of Shiva,
Yes.
and the down and the
Yes.
little boy there is
Yes.
is the demon called Apasmara, and he's
That's
the
wonderful.
one
Yes.
which is the source or epilepsy. Apasmara is epilepsy.
Yes.
Apasmara
Yes.
in literal term of Sanskrit, it would mean altered memory. Smarana is memory.
Right.
Apa is altered memory. Because in
Right.
epilepsy, ultimately people develop
Yes.
altered memory.
Yes.
They don't
Very
remember what
interesting.
happened. Yeah. It can be a good
Very
emblem
interesting.
for an epilepsy conference.
Yes.
That's very nice.
Thank
Thank
you
you,
very much. That's
Dr.
wonderful.
Thank you very much, Dr. Khilari. It was an excellent talk, very good discussion among the audience. And we are grateful for this talk. And it's about time to say goodbye. We'll meet again.
Thank you very much. Thank you for the opportunity. Thank you.
All right, take care. Bye.
Thank you. Bye.
Jigyasa, you can stop the recording.